Hello everyone in CardioMinds channel and with part 3 of the topic of treatment of acute coronary syndrome, and today we are discussing an interesting topic regarding the use of triple antithrombotic therapy and what are the alternative antiplatelet strategies. Let's start with the triple antithrombotic therapy. Let's introduce ourselves at first to the 4 pivotal trials that were testing non-vitamin K oral anticoagulants versus vitamin K antagonist as part of triple antithrombotic therapy, like the Pioneer AF PCI trial testing Edoxaban, Redual PCI trial testing Dabigatran, AUGUSTUS trial testing Edoxaban, and the ENTRUST-AF PCI trial testing Edoxaban. We will find the link for these 4 clinical trials in the description below the video. We should emphasize that the P2Y12 inhibitor of choice that was used most frequently in these trials was clopidogrel, with less use of ticagrelor. We should take care of this point. That's why we are going to use it later on. The first recommendation we are discussing today is that the default strategy for patients with atrial fibrillation and chest VASCA score more than or equal 1 in men and more than or equal 2 in women. And remember that a patient with atrial fibrillation who was discovered to have ischemic heart disease in the coronary angiography, in this case the score would be at least 1, so we will have an indication for lifelong oral anticoagulation. He should receive up to 1 week of triple antithrombotic therapy following the acute coronary event, and in this case we mentioned up to, so it could be less than 1 week. For example, if the patient will be discharged after 4 or 5 days from the onset of the acute coronary event, you can omit aspirin in the prescription, provided that you prescribed aspirin during his hospital stay. Then you can start dual antithrombotic therapy using an anticoagulant, better to be NOAC as the recommended dose for stroke prevention, so it would be the therapeutic dose, and a single oral antiplatelet agent, preferably clopidogrel, for up to 12 months. So non-vitamin K oral anticoagulant is preferred over vitamin K antagonist in case of triple or dual antithrombotic therapy, and the single oral antiplatelet agent that the patient will continue on preferably is clopidogrel. So far there is limited evidence to support the use of oral anticoagulant with ticagrelor or prasugrel as dual antithrombotic therapy after acute coronary syndrome or PCI as an alternative to the triple therapy, as ticagrelor was used in just 5 to 12% and prasugrel in just 1 to 2% of patients respectively in the 4 pivotal clinical trials testing NOACs versus vitamin K antagonist. That's why clopidogrel is a P2Y12 inhibitor of choice in the dual and the triple antithrombotic therapy. If the patient is already anticoagulated, unfractionated heparin bolus is recommended during PCI in case of a patient on NOAC, and remember that in those patients it is unknown whether to bridge NOACs with parenteral anticoagulants or to continue NOACs without additional parenteral anticoagulation, but the recommendation that those patients should receive an unfractionated heparin bolus, and if the INR is less than 2.5 in VKA treated patients, because if the INR is more than 2.5, in this case no parenteral anticoagulation is needed. This is in case of acute coronary syndrome in general, but if the patient is having STEMI, is there a difference if he is anticoagulated or not? Patients with STEMI who have a higher atherothrombotic risk than those with non-ST elevation acute coronary syndrome were underrepresented in the major clinical trials, just 10% of the study population. And so a common practice based on the 2017 ESC Guidelines of STEMI that those patients with STEMI and who are already anticoagulated should receive parenteral anticoagulation during PCI, regardless the type of oral anticoagulant or the baseline INR. In some cases, we give just 60 units per kg if the patient is having STEMI and already anticoagulated, but to omit parenteral anticoagulation in a STEMI patient, in this case, not all doctors will follow this rule. And of course, don't give parenteral anticoagulation unless you detect the coronary anatomy in the angiography that the patient needs PCI. So let's revise. Acute coronary syndrome in an anticoagulated patient, either STEMI or non-ST elevation acute coronary syndrome, POS should use radial approach during catheterization, add proton pump inhibitor because those patients are at risk for GI bleeding, give loading dose of aspirin, but loading dose for P2Y12 is only clopidogrel after deciding for PCI, and avoid preloading, so we only give clopidogrel after you detect the coronary anatomy that the patient needs PCI, and glycoprotein 2B3A inhibitor only for bailout therapy as downstream. And in case of STEMI, avoid fibrinolytic therapy as the oral anticoagulation is a relative contraindication, so better to proceed for primary PCI rather than fibrinolytic therapy, and give parenteral anticoagulation anyway during primary PCI, even a reduced dose of unfractionated heparin. In case of non-ST elevation acute coronary syndrome, we only give parenteral anticoagulation if the patient was on NOAC or the patient on VKA and INR less than 2.5. Some patients cannot receive NOACs as an oral anticoagulant and they should receive VKA. For example, those with mechanical prostatic valves or those with moderate or severe mitral stenosis, which is almost always rheumatic in etiology. So you combine VKA with aspirin and or clopidogrel with target INR here is just 2 to 2.5, not 2 to 3, and the time in the therapeutic range, abbreviated as TTR, should be more than 70%. This is a class 2A recommendation, and beware that patients with prostatic mitral valve may need a higher target INR, for example 2 to 3, because they carry a higher risk for thromboembolism. Some patients may have a high bleeding risk based on the academic research consortium, which has major criteria and minor criteria. So here, if the bleeding risk is higher than the risk of ischemic stroke, we can use rivaroxaban just 15 milligram once per day rather than the other standard dose of 20 milligram. This is a class 2A recommendation for the duration of the concomitant single or dual antiplatelet therapy, and the same recommendation for Dabigatran. We can use just 110 milligram twice per day rather than the standard 150 milligram twice per day for the duration of the concomitant single or dual antiplatelet therapy, and this is also a class 2A recommendation. You can find the explanation for the assessment of the bleeding risk by the Academic Research Consortium in part 1 of the treatment of acute coronary syndrome. What about if you decided that this acute coronary syndrome patient will receive conservative treatment rather than PCI and he has an indication for oral anticoagulation? In this case, you can use just a single antiplatelet agent. Usually it would be P2Y12 inhibitor in addition to oral anticoagulation for up to 1 year. This is a class 2A recommendation. So you use here just dual instead of triple antithrombotic therapy because this patient did not have PCI. And the use of aspirin in those patients in comparison to the placebo has led to more bleeding events in the AUGUSTUS trial, but no significant difference in the rate of death, hospitalization or ischemic events. That's why it is better to omit aspirin and continue on P2Y12 inhibitor with the oral anticoagulants. In some patients, the ischemic risk is higher, and so 1 week is not enough in those having an indication for oral anticoagulant. That's why you use oral anticoagulant with aspirin and clopidogrel for longer than 1 week up to 1 month. This should be considered in those with high ischemic risk or with other anatomical or procedural criteria that mean that the ischemic risk here outweighs the bleeding risk, and this is a class 2A. So the maximal duration for triple antithrombotic therapy is just 1 month in those with high ischemic risk. Let's give some examples of the high risk features of stent-driven recurrent ischemic events. For example, patient having prior stent thrombosis on adequate antiplatelet therapy, stenting of the last remaining patent coronary artery, diffuse multivessel disease, especially in diabetics, those with CKD, at least 3 stents or 3 lesions treated, bifurcational lesion with 2 stents implanted, total stent length, sometimes we call it the metal jacket, more than 60 mm, and treatment of chronic total occlusion by stent or more. In some patients, you may withdraw antiplatelet therapy after 6 months and continue only on oral anticoagulation. This is just a class 2B because the strongest evidence so far is to stop antiplatelet therapy after 1 year and then continue on oral anticoagulants. And the big no that the use of ticagrelor or prasugrel as part of triple antithrombotic therapy is not recommended. So far it is a class 3 recommendation. You only use aspirin plus clopidogrel plus oral anticoagulant, preferably non-vitamin K oral anticoagulants. In dual antithrombotic therapy, so far clopidogrel is preferred to ticagrelor or prasugrel. As we mentioned, they were not tested so much in the pivotal clinical trials, but in the triple therapy it is contraindicated to use one of them. We mentioned the recommendation for those having PCI or conservative treatment. What about those treated with CABG and having an indication for oral anticoagulation? In those patients, you should resume oral anticoagulation plus single antiplatelet therapy after CABG as soon as possible, and better to avoid triple therapy, because in a network meta-analysis, the dual antithrombotic therapy including VKA and clopidogrel compared with the triple therapy including VKA, aspirin and clopidogrel was associated with a trend towards a reduction in the TIMI major bleeding after CABG with no significant difference in the major adverse cardiac events. I know that some of you may say that here the oral anticoagulant used was VKA. This explains the higher bleeding risk in those treated with triple therapy after CABG, but the concept is the same. Triple therapy carries a higher risk than dual therapy, either if you are using VKA or using oral anticoagulant. That's why avoid triple therapy after those treated with conservative treatment or those treated with CABG. And this interesting diagram explains the recommendations that we discussed shortly regarding the default strategy for triple antithrombotics and dual antithrombotic therapy, and the other strategies that we may use in those with high bleeding risk or those with high ischemic risk. Now we are moving to the alternative antiplatelet strategies, which includes shortening or de-escalation or prolonging antiplatelet therapy. We have a famous clinical trial called the Twilight trial, which examines the effects of ticagrelor monotherapy after receiving 3 months of dual antiplatelet therapy versus continuing dual antiplatelet therapy with ticagrelor and aspirin for 1 year, and the incidence of these treatment strategies on the clinically relevant bleeding in non-ST elevation acute coronary syndrome patients. STEMI was excluded in this trial. The enrolled patient here had at least 1 clinical and 1 angiographic feature associated with a high risk of ischemic or bleeding events, but without major bleeding or ischemic events in the 3 months following hospital discharge. The results that the bleeding event were significantly reduced by omitting aspirin after 3 months and continuing just on ticagrelor monotherapy without a signal of increased ischemic risk. Another famous trial that I know many of you may have heard about, the TICO trial, and you will find the links for all these clinical trials in the description below the video. It examines the effect also of ticagrelor monotherapy after 3 months of DAPT versus ticagrelor plus aspirin for up to 1 year in 3,056 acute coronary syndrome patients, but here 36% of the tested patients were STEMI, unlike the Twilight trial which excluded STEMI. The results that the net adverse clinical events and major bleeding events were significantly reduced with ticagrelor monotherapy, and the major adverse and cerebrovascular events were not significantly different. But the limitations of the TICO trial that there was lower than expected events rate. That's why not all the doctors may take the results for granted, but of course Twilight and TICO trial emphasize the use of ticagrelor monotherapy after 3 months of DAPTs. Another different trial which has the same concept but with a different perspective, Stop DAPT2 ACS trial. It investigated the short DAPT strategy in acute coronary syndrome patients, as at the first or the second months patients were randomized to either clopidogrel monotherapy or continuing DAPT for 12 months. But here, the non-inferiority of the investigation strategy for the composite endpoint of cardiovascular or bleeding event was not proven. That's why the very short duration of DAPT, less than 3 months, followed by clopidogrel monotherapy, so far it is not a useful strategy. This means that the 3 months is the minimal duration for DAPTs. Based on these clinical trials, there is a recommendation that if the acute coronary syndrome patients were event-free after 3 or 6 months of DAPT and they are not having high ischemic risk, we can continue single antiplatelet therapy, preferably P2Y12 inhibitor. So you stop the aspirin and continue the P2Y12 inhibitor. This is a class 2A recommendation. So the minimum duration, as we mentioned, for DAPT is 3 months. And in those with high bleeding risk, class 2B, that you can continue on aspirin or P2Y12 inhibitor monotherapy. So you stop either one of them after 1 month of DAPT. But so far, the strongest recommendation is for the minimal duration of DAPT to be 3 months as a class 2A recommendation. In some patients with high bleeding risk, we can have a de-escalation of the P2Y12 inhibitor, meaning a switch from prasugrel or from ticagrelor to clopidogrel as an alternative strategy to reduce a bleeding risk. This is a class 2B recommendation, but of course it is a common practice in those with high bleeding risk on prasugrel or ticagrelor. This can be done based on a guided approach by a genotyping based on the popular genetics trial that produced de-escalation in acute coronary syndrome patients undergoing primary PCI within the previous 48 hours, and it was proved to be non-inferior to the standard treatment with ticagrelor or prasugrel at 12 months as regards the thrombotic events, and of course with a lower incidence of bleeding. Or unguided approach based on the topic trial. Here the de-escalation was done in acute coronary syndrome patients, either non-ST or STEMI, to clopidogrel after 1 month of DAPT with ticagrelor, prasugrel, and aspirin. And here the net adverse clinical events and the bleeding events were reduced, whereas the rate of ischemic endpoints was unchanged. And the TALOS AMI trial had the same approach with significant reduction in the net adverse clinical events and bleeding events. However, we should be aware that much of the evidence on these strategies is derived from trials powered primarily for bleeding outcomes, not for the ischemic outcomes, and many of which had a non-inferiority design, so they are not powered to detect potentially relevant difference in the ischemic events. This explains why these recommendations are just class 2B. Also, the patient populations enrolled in these studies were relatively selected, excluding the highest risk acute coronary syndrome patients. That's why de-escalation should not be a routine strategy. It should be an exception in those with high bleeding risk, but not to be generalized. And the big no that the de-escalation of antiplatelet therapy should not be done in the first 30 days after acute coronary syndrome. So you should not stop aspirin and continue on P2Y12 alone in the first months, and better to avoid de-escalation from ticagrelor or prasugrel to clopidogrel, except in a specific recommendation in which we use clopidogrel as an alternative to prasugrel or ticagrelor. And another interesting diagram that explains the abbreviated DAPT strategies and the de-escalation strategies that we can use in the acute coronary syndrome patients based on the recommendations that we discussed shortly. In some patients, you may prolong antithrombotic therapy due to high ischemic risk. As we discussed in the triple therapy, that we discontinue antiplatelet treatment in patients treated with oral anticoagulation after 12 months. As we remember from this diagram, that beyond 12 months, we stop antiplatelet and continue only on the oral anticoagulation therapy, and this is a class 1 recommendation. Nothing is called that you continue aspirin with the oral anticoagulation lifelong, because this patient is ischemic and also having an indication for oral anticoagulation. This increases the bleeding risk significantly. Only continue on oral anticoagulants. This table here shows us the famous clinical trials that tested the dual antithrombotic regimens for extended treatment. like the COMPASS trial testing the 2.5 mg twice per day dose of rivaroxaban, the DAPT trial that tested clopidogrel, and another DAPT trial testing prasugrel, and the Pegasus TIMI 54 trial that tested the 60 mg dose of ticagrelor twice per day, which was associated with reduced bleeding events compared with the 90 mg twice per day. That's why it should be preferred for extended therapy of ticagrelor beyond 12 months. So there is a recommendation that you can add a second antithrombotic agent to aspirin for extended long-term secondary prevention beyond 1 year. Should be considered in patients with high ischemic risk without high bleeding risk, and this is a class 2A recommendation. And the evidence supporting this approach is based on trials in which the duration of prolonged treatment was 23 months in the COMPASS trial testing rivaroxaban 2.5 twice per day, 18 months in the DAPT trial, 33 months in the Pegasus TIMI 54 trial. Therefore, the benefits and risk associated with continuation of these treatment, either adding rivaroxaban 2.5 mg twice per day or adding another P2Y12 inhibitor for extended lifelong treatment, should be considered only in this treatment duration. Beyond these time points is still unclear. Class 2B is that you may add a second antithrombotic agent to aspirin for extended long-term secondary prevention in patients with moderate ischemic risk without high bleeding risk. This is just class 2B. And P2Y12 inhibitor monotherapy may be considered as an alternative to aspirin monotherapy for long-term treatment. This is also not an uncommon practice, as sometimes a patient has a contraindication to aspirin, for example, severe gastritis or gastric ulcer, aspirin allergy, or ototoxicity. In this case, we stop aspirin and continue on P2Y12 inhibitor monotherapy. But an important question: when should we consider this patient at high ischemic risk or moderate ischemic risk? This table shows us who are the patients at high thrombotic risk, like with those with complex coronary artery disease and at least one criterion from the risk enhancers or the technical aspect related to PCI that puts this patient at high thrombotic risk, or those with moderate thrombotic risk having non-complex coronary artery disease and at least one criterion from the risk enhancers or the technical aspect related to PCI. In this case, we can consider the patient either at high or moderate thrombotic risk to decide whether this patient would need extended lifelong treatment with another antithrombotic agent. And another interesting diagram shows us all the antithrombotic strategy for long-term secondary prevention beyond the first 12 months after acute coronary syndrome. So let's summarize what are the suggested strategies to reduce bleeding risk related to PCI. Of course, the anticoagulant doses here should be adjusted to body weight and kidney function, especially in females and older patients. It is not a fixed standard dose for all patients regardless of their weight or their age. Radial artery approach is the default vascular access to reduce vascular complication and bleeding risk. PPI should be added to those on DAPT with higher than average risk of GI bleeding, including those on oral anticoagulation. And those on oral anticoagulations, in this case, as we mentioned, PCI should be performed without interruption of the VKA or NWAC. Patients on VKA do not administer unfractionated heparin if INR more than 2.5. In those with STEMI, we may add a reduced dose. Patients on NWAC, regardless of the timing of the last administration of NWAC, add a low dose of parenteral anticoagulation like enoxaparin 0.5 mg per kg IV or unfractionated heparin 60 unit per kg. Aspirin is indicated, of course, but avoid pre-treatment with P2Y12 inhibitor until you detect the coronary anatomy and that this patient will have PCI. And as we mentioned before, glycoprotein 2P3A inhibitors only for bailout or peri-procedural complications, not as an upstream therapy. The last point to mention today in our video is the antithrombotic therapy in patients not undergoing reperfusion. Those patients with a final diagnosis of acute coronary syndrome who do not undergo reperfusion should receive aspirin plus P2Y12 inhibitor for 12 months unless there is a high bleeding risk. In this case, aspirin plus ticagrelor or aspirin plus prasugrel showed superior clinical outcomes to aspirin plus clopidogrel unless there is a high bleeding risk. So aspirin and clopidogrel may provide a good net clinical benefit among older ACS patients who have higher bleeding risk, but the preferred strategy for 12 months is aspirin plus ticagrelor or aspirin plus prasugrel in those having conservative treatment. So in those patients, don't stop P2Y12 inhibitor. It is still indicated even in absence of PCI or CABG. So we have reached the end of part 3 for the treatment of acute coronary syndrome, and of course I know that it is difficult to have a unified take-home message summarizing all the information that we mentioned in the 3 videos, but we can mention the important concept that the choice of treatment strategies in patients with STEMI or non-ST elevation acute coronary syndrome regarding pharmacotherapy or invasive strategy depends on 2 related factors that you should put in your minds. First of all, the clinical and risk assessment of this patient, including the ischemic risk and the bleeding risk, and don't forget the evidence-based treatment. Try as much as you can to follow the recommendations in the guidelines and do not do other practice unless there is an evidence or a consensus opinion for this recommendation. Thank you very much for watching this video, and we are still having some few videos to end the guidelines of acute coronary syndrome, so we are meeting next week.